All right, welcome to Grand Rounds in July. Today we have Dr. Brian Owens. He is a physical therapist and clinic director in two of our outpatient sites in New Jersey. And starting next month, he will be network director of inpatient rehab. He is very well versed in dry needling, and he earned his Doctor of Physical Therapy at Arcadia University. And he earned his, he's working on an executive MBA at, I apologize, Kane University. So, without further ado, Dr. Owens.
Good morning. Thanks for coming this morning. How many people have experience with dry needling? How many people have dry needled? Unless you're in New Jersey, you haven't done it here in PA. How many people have had acupuncture? How many people have performed acupuncture? How many people don't give a hoot? Okay. All right. So, you know, I think the bird's eye view of dry needling generally is much more scary and alarming than it actually is when you actually take the time to, peer at the research that's out there. Take a course that's provided by numerous continuing education providers regarding the dry needling. It's always much more scary to look at it from a bird's eye view than actually get in and see how beneficial it is for many of our patients. The research, there's a paucity of research out there right now that is really showing that it is by and large no better than sham treatments alone, or better than nothing at all. And the problem with that is that, one, we're still looking a lot at the acupuncture literature that's out there and not necessarily looking at dry needling. So dry needling is performed by acupuncturists, but the philosophy and reasoning for doing such are two completely different things. It's apples and oranges for the most part. In a chiropractic setting, chiropractors would use dry needling and call it chiropractic. In physical therapy, physical therapists would use dry needling and call it physical therapy. Acupuncturists may be doing dry needling as well and calling that acupuncture. They're not the same thing. So the lecture objectives today, what we're going to be doing is we're going to be talking about dry needling, define it so you know what it is exactly and how it can be implemented in an eclectic approach to physical therapy practice. At the completion of the lecture, we're going to understand the history surrounding the use of dry needling and physical therapy practice. We're going to understand the current legal challenges facing physical therapists in the performance of dry needling, and we're going to understand the aspects of dry needling safety trends in the literature and recommendations for dry needling application in clinical practice. So this is a huge topic to discuss and unravel in 50 minutes, right? So this is pretty much going to be an introduction to the topic by and large. And we're going to do first to start off with a brief video to give you an overview of what it is exactly. Steve.
Use the mouse to click on it. There it is.
Oh, there we go. All right, here we go.
Unfortunately, you have to listen
very closely.
The volume is not working on the system.
I gotta pull the screen down. There we go. Can anybody hear that? Okay, so So this looks awful, right? You're kidding me? He's going to put a needle in her neck. Oh my gosh, it looks terrible. So this is actually probably one of the best dry needling videos that you can find on the internet. There's a lot of awful things that if you go and you look at YouTube, there are people that are utilizing the technique. They're doing it poorly and in a cavalier fashion. They're not really well versed in doing the technique and are just showing what they typically do in the clinic. This particular therapist is using a clean needle technique Meaning he's utilizing gloves. There's a sterile treatment area. The needles that he's using are sterile themselves. He is He's very, very cautious. When you're utilizing dry needles, it is not something where someone has pain, they say it hurts here, and I put a needle in the body. That's not how it works. So there is a reason for why we're doing it. Dry needling is a piece of the puzzle for physical therapists. One more tool in our toolbox to utilize problems with the neuromusculoskeletal system. So what he's essentially doing when he's dry needling what looks like to be her sternocleidomastoid is he knows where the needle is at all times. If you're putting a needle in someone's body, that's really important. So a lot of times you'll look at videos on YouTube and you'll see them putting needles in the body, inserting into the tissue, the needle disappears, and you see the needle moving back and forth, and you're wondering, how does he know where the needle is? He probably doesn't. This particular therapist does because he's bracketing the sternocleidomastoid between his fingers. He's inserting the needle on one side. As he inserts the needle, he can feel the pressure change on the opposite side of his finger, so he knows where the needle is at all times. That is incredibly important in performing the procedure. When you're doing a deep procedure, so if you're dry needling the glute medius or glute minimus, the outer portion of the hip, most oftentimes they will be going all the way to the ilium, to the bony surface. So they know where the endpoint is of the needle. They're never going to insert it into the middle of the abdomen and just say, geez, I hope it goes well. It doesn't work that way. Right? So it is a very precise, exact way to identify issues with the musculoskeletal system and how the nervous system is communicating with the musculoskeletal system. That was a very good video. Bottom right. Sorry about this. Gotcha. There you go. Perfect. All right. Onward and upward. Okay, so what is dry needling? Dry needling is a skilled intervention that uses a thin filiform needle to penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissues for the management of neuromusculoskeletal pain and movement impairments. That is the official definition provided by the description of dry needling in clinical practice, which was a white paper or an educational resource paper provided by the American Physical Therapy Association. So those are essentially acupuncture needles. There are different types of needles that are out there. There are now needles that are being produced by a physical therapy company specifically for the use of dry needling, and they basically have a metal stem, and that is to be utilized with an electrical current. So they can actually stimulate the motor point or stimulate the needle while it's inside the person's body. Those are acupuncture needles. Basically, it's a solid fine monofilament needle. They vary in thickness and size. Initially utilized for pain-based model management. Now the novel application for it, or a newer application for it, is not only to address pain, but to address movement. Right? So that's very, very important and restore the patient's level of function. So dry needling is intended to be an application of high-quality care. It is not the holy grail. It is not you come into my clinic and say, I want to be needled. That makes me raise my eyebrows, to be honest with you. When someone comes into the clinic and says, please needle me, no. So the reason why I'm going to dry needle someone is because I feel like they fit the appropriate model for that. We'll talk about particular patients that may benefit from it. If we're going to pan out and look at diagnosis, what kind of diagnoses may be beneficial in utilizing dry needling. But it is something that is to be used in more of an eclectic approach, at least the way that I've been instructed to do it. Okay? It's a treatment of the neuromuscular system based on muscular system impairments, knowledge of anatomy, and pain patterns. This is where it differs from acupuncture. So the acupuncture, as we'll talk about, was adopted in the U.S. or the Western world in the 70s, and then basically the needles were used and the techniques were used and applied in a different manner the way that we approach medicine here. Right, so I'm looking at muscular system impairments, my knowledge of human anatomy, three-dimensional anatomy. When I look at Ethan's shoulder here, I can look at the front of his shoulder and visualize what's on the front, what happens when I hit his humerus, and what's on the opposite side of the joint. That's very important to me as a physical therapist when I'm utilizing dry needling. Knowledge of the central nervous system, myotomal patterns, testing out myotomes. Am I going to identify whether or not this is a problem with the peripheral nervous system, or is this something that needs to be treated more centrally at the spine? And I'm also looking at pain referral patterns. There are trigger point patterns that have been established for a number of years, starting in the 1940s, which basically a muscle can refer pain to distal parts of the body, that's going to be important for me because some of those things may look like it is a spine problem when it really just could be a muscular issue. I think with the dry needling, a lot of times where we go wrong is that when you have a hammer, everything looks like a nail, right? And so that's really not the case with dry needling. It depends upon the examination and the assessment and guide to treatment. Test, treat, and retest. The strategy for utilizing dry needling really should be no different than the strategies that I'm using for manual therapy. As a manual therapist, when someone comes into my clinic and they say they have shoulder pain, I want to know what hurts. I want them to point specifically to where the problem is. I want them to demonstrate the movement that is an issue. So that way when I provide intervention, I can go back and have them do the same exact thing so I know whether they're better, worse, or no different. It's not a complicated issue, but it helps me identify whether or not the intervention that I'm providing is actually beneficial to the patient. One of the education providers that's out there that's a leading education provider also uses global movement patterns, or what's known as the selective functional movement assessment, which is basically a global way to look at quote-unquote normal movement and identify whether or not the patient is having a particular problem with performing a specific activity, and a way for us to objectively state that the patient's improving. Dry needling is going to be used in conjunction with manual therapy and therapeutic exercise. So the trigger point theory, this is where we start in the 1930s. Two British researchers, Sir Thomas Lewis and John Kellgren, were working as partners in the lab. Kellgren was working as an understudy of Sir Thomas Lewis and basically found that injections of saline solution into muscular tissue led to pain in the tissue distant from the site of the injection. So first off, there's a difference between a wet injection and a wet needle and a dry needle. A wet needle would be what? It's a needle that carries a substance used to treat pain, inflammation. A dry needle doesn't have anything coming out of it. So, and they're much thinner, finer needles. They produced some landmark studies in studying of somatic pain and referred pains from the muscle. They found in the early research that pain was actually referred specific to a muscle. So for example, if I have a problem at my glute minimus, it may very well present like a lumbar spine radiculopathy. I may have pain traveling down my leg and the back of my hamstrings down to the outer portion of my lower leg. May not necessarily be the spine. There may be correlation there and reasons why I may need to go look at that, but that can also be coming from the muscle as well. And they both found that the relief via injection of procaine into tender points, they found distant to the site of pain. So muscle confusion. This has nothing to do with Tony Horton or Beachbody. If you're familiar with that, this is not what I'm talking about, right? Numerous terms used to describe pain arising from the muscles in the 19th and 20th centuries. There was too many terms to describe one basic problem. So you had tight bands, tender nodules, you had muscular rheumatism, fibrositis, rheumatic myalgia, non-articular rheumatism, fibromyositis. That's enough to make your head spin when they're all talking essentially about the same thing. J.H. Kellgren, as I said, was the first to publish detailed illustrations of pain referral patterns. He noticed this on the observations of referred pain, which is arising from a muscle, which that study is listed there. And his work essentially sparked international interest in the use of anesthetic injections into tender points. Harmon and Young in 1940, they found that thoracic spine musculature tender points stimulated visceral pain eliminated with injection into the points. So they were touching various portions of the thoracic spine musculature, and it was stimulating visceral pain. That got them to scratch their heads a little bit and found that when they actually injected the muscle, the visceral pain went away. Steinler in 1940 may have been the actual first person to utilize the term trigger point. Every researcher wants to be the first to do something like that because then they can name things after themselves, right? So the use of the term was not necessarily confined to myofascial trigger points, and that was different in his study. And he looked at other sites of referral, including the muscle, the tendon, the ligament, and the nervous tissue. So he kind of branched out beyond just the muscle tissue itself. So here you have Janet Travell, which myofascial trigger point concept was developed in 1942. She became longtime partners with Dr. Simon, who continued to participate with the emergence of dry needling research. Janet Travell was actually befriended John F. Kennedy and very early on in his role as a Massachusetts senator in 1955, all the way up to the point of his assassination. She was a White House physician and actually stayed there with Lyndon B. Johnson as well to continue in her role there. John F. Kennedy had low back problems notoriously, and she was the person, if he's famously sitting in that rocking chair, she was the one that actually recommended that, and she used to provide trigger point injections to his lumbar spine. So what is a trigger point? It's a hyperirritable spot in the skeletal muscle that is associated with a very sensitive or hypersensitive palpable nodule in a taut band. The spot's tender when pressed, can give characteristically referred pain related to motor dysfunction and autonomic phenomena, right? So what are trigger points, right? We have active trigger points, we have latent trigger points, and satellite trigger points. Active trigger points are those points that are the points that are present when a patient sits in front of you and they have pain or they're aching at rest. There's nothing that you need to do to poke on it or push on it to cause it to hurt. It's hurting when they're sitting there. The latent trigger point is painful with palpation, but it's not really a familiar sensation to the patient. So generally you'll find that if a patient's laying in front of you and you poke on a lot of things, they'll say ouch, but it's not their primary complaint, right? But that may exhibit all the features of the active trigger point. The satellite trigger point can be active or latent, but generally develops in the referral zone of the active or latent trigger point. So that is something that may be, I may push deep to their glute medius and glute minimus, and it may refer pain to the lateral portion of the lower leg. That would be an example of a satellite trigger point. It's showing up distant from the site of provocation. And the referral patterns are really important, and this is where a lot of the research here and confusion sets in to the average consumer and educator when they're looking at trigger points. And so a lot of people think that Travell and Simons, they have two very important books in this area called the Red Books, which basically they outline trigger point referral patterns throughout the entire body, and people assume that the axis is where the trigger point is. That's not the most important information that you're going to glean from this data. It's really the actual site of referral pain. So the glute medius can actually present as low back pain. It could look like a sacroiliac issue. It could present as pain in the glute max and proximal hamstring. So that's really the most important thing to take from those, not necessarily X marks the spot. It was actually where a lot of the confusion came from with saying that acupuncture is the same thing as dry needling and that their trigger points are the same thing as the zones or meridians that acupuncturists are using. Is not correct. So the biggest thing you can take from that is the actual site or region in which that particular muscle refers pain to. So finally, dry needling emerges, right? So trigger points may cause referred pain and pain which mimics the visceral conditions. We talked about that earlier. Travell also found that in 52, noting that the trigger points can produce autonomic phenomena. An example of that related to dry needling would be fasciculations or muscle twitching with activation of a particular muscle. In the 60s, the trigger point concept became commonplace in Western medicine. 60 to 75, very little literature was produced on trigger points or dry needling in the West. Nothing worth mentioning. But in the 70s, East meets West, right? So Eastern medicine comes over to the West. Acupuncture is noted as a possible benefit in pain management, but this also encourages further research in dry needling. Additional studies find similar success between techniques. They're looking at acupuncture techniques, with acupuncturists that are trained in traditional Chinese medicine, which is not what dry needling is used for in the West, was very similar in its success to actual dry needling techniques, taking a needle and putting it in a trigger point. And the reason why they found similar success, and this study with Melzack in 1977 was one of the ones that said that many of the referral patterns related to those trigger points is very similar and lines up with a high percentage of the meridians, which later they found to be incorrect because, as I said, they were using the X marks the spot theory versus the actual referral patterns or sites of pain. Lewitt in 1979, this is a landmark study for dry needling. So the needle effect in the relief of myofascial pain. This is a report that resulted when they found that needling a tender point without an injection actually improved the patient's symptoms. So they were finding, oh my gosh, if I put a dry needle into a patient's trigger point, they get better as well. I don't have to put anything in their body. So tender points, scars, ligament, periosteal, that means bone insertions to the bone, right? They found acupuncture needles safer, less bleeding and bruising occurred with those needles versus the hypodermic needles or the wet needles. That is why in the West we began to adopt utilizing acupuncture needles, is because they found that when utilizing those with patients, they had less pain, they had less bruising, and it was generally safer to them. So here we separate between dry needle city and acupuncture valley. We begin to go in different ways in the 70s. Okay. Dry needling terminology is, as any new modality or treatment comes about in any profession, it takes a while to figure things out. We're at the figuring things out stage and getting to the point where we're producing a lot of good research. Compared to 2005, I've heard that the literature that's out there is increased by about 500% with dry needling. There's almost a new randomized controlled trial coming out every week in every new medical journal, rehab journal. There's new studies that are coming out. That is because we are now looking at dry needling versus just comparing using some of that acupuncture literature. So the APTA in 2009 called it intramuscular manual therapy, found that to be somewhat confusing. The idea being that the needle is inserted into the muscle, that makes sense. Dry needling was the umbrella term that was adopted in 2011. There's a group out there, Kineticor, they're one of the largest continuing education providers for dry needling. They call it functional dry needling, and I'll talk about why. And trigger point dry needling is essentially the universal term which emphasizes treating the trigger point. So in physical therapy and dry needling, how does dry needling fit into PT? It's a tool, nothing more, nothing less. It's a way that we can change muscle tone, decrease pain, and restore function, which is altered by the neuromusculoskeletal system. Right? It's a lot easier, a lot less stressful for me as a clinician to not have to use my hands, my fingers, my elbows, my back, my knees when utilizing manual therapy to address soft tissue. I'm not utilizing dry needling for myself. I'm doing it for my patients. Patients generally will find, you couldn't hear the video unless you could read lips, but the guy was essentially saying that muscles that aren't a problem when the needle is inserted generally is hardly perceived by the patient. Right? And we'll talk about what happens when you actually insert the needle in just a few slides. Dry needling is not a treatment. Patient doesn't come in for dry needling treatment. If there is a script that comes in and just says dry needling, I scratch my head. I'm responsible for my own actions. I'm very prudent and wise with the way that I implement dry needling. This is not something where we're talking about ultrasound or e-stim. This is a treatment or an intervention that essentially can hurt someone if you're not careful, but overall is very, very safe. It's a small component to physical therapy intervention, just a piece of the puzzle. It's considered to be within the PT scope of practice in 35 states. This is not a fad. It's not going anywhere. It's only going to get approved probably across every state in the country is my hope, and the research is going to keep getting better and better. Our professional association, if you're not a member, please become a member, is very, very serious about this intervention. It's actually in our guide to PT practice now, so it's not going anywhere. Application has increased dramatically by PTs since 2005. Numerous entry-level programs are beginning to introduce a theoretical model in which dry needling treatment is based upon. It is not legal. It is outside the scope of practice for a physical therapist in the state of Pennsylvania to utilize dry needling. That includes teaching that in entry-level programs. Teaching the theoretical model is much, much different. Okay? We'll talk about state by state what the differences look like. It's not only a model for dry needling, but as I said, can also be applied to manual therapy. So the same model that I'm going to think about using dry needling, I'm going to look at manual therapy as well. So what are the physiological effects of dry needling? So it's going to increase blood flow. It causes a local inflammatory response to the particular muscle, increases blood flow, improves oxygenation to the tissue, and increases the nutrients that are actually getting to the tissue. When we talk about decreased banding of dysfunctional tissue. So the banding of the dysfunctional tissue is actually part of the inflammatory mediators that are going to come in when you have an acute tissue injury. So oftentimes the tissue is flooded with neurotransmitters, including acetylcholine. Though that floods the tissue, that causes shortening of the sarcomeres and banding or tautness or nodules within the tissue. A decrease in spontaneous electrical activity. Dysfunctional muscle tissue has a higher level of electrical activity than muscle tissue that there isn't a problem with. That is characteristic of neuromuscular dysfunction. A rapid insertion of the needle produces a local twitch response. Previously it was thought that the twitch response was something that was necessary for success of the needling procedure, and again that twitch response is the moment I insert the needle, the muscle twitches. That immediate discharge of electrical activity in the muscle does a couple of things. One, it is set to a reset tone by changing the neuromuscular junction and the neurotransmitters and everything that's getting to that tissue to allow it to provide electrical activity and generate motor function. And it also is said to decrease the amount of acetylcholine within that particular tissue to restore normal resting length of that particular tissue. Biochemical changes. Dysfunctional tissue has an abnormal biochemical balance. These are studies that previously they were relying on acupuncture literature to identify what actually happens when you put the needle in the body. Now there are dry needling studies are coming out. This study by Shah in 2005 and 2008 was actually used on human tissue. So this is a very significant study. And what he found was that there were basically elevated hydrogen ions and neurotransmitters, cytokines and chemokines. Those are all really big words, right? But generally what they are is inflammatory mediators. They are proteins which signal other cells to attend to or go to the area of inflammation or trauma, primarily white blood cells, right? Changes to the central nervous system in 2012. That's not only just a peripheral response. The CNS is actually involved. We learned, the gate theory in college and the release of endogenous opioids. Those are two mechanisms in which you're seeing pain relief from a central standpoint, meaning the brain and the spinal cord. Okay, when you're performing the actual dry needling, and you have local changes to substance P, right, which is going to help minimize pain with the dorsal root ganglion. So C. Chan Gun, so it finally gets its legs in the West. In 1974, a Canadian physician developed interest in acupuncture, began using it in the West, and developed a dry needling approach using various needles and various needling techniques. He called it intramuscular stimulation, or gun IMS. This is different than some of the other theories that are out there, primarily because when you're looking at the trigger point theory, you're treating the muscle. He is also looking at the spinal segment, meaning that when we talk about testing things out, as was mentioned earlier in the video, patients that come into the clinic, I'm doing my assessment just like I would if they had any other orthopedic injury, but I'm also doing myotomal testing too. I want to know whether this is a peripheral problem or a central problem. And I can identify that by testing multiple muscles within the same myotome, because more often than not they have different peripheral nerves. If they're both a problem, then I know it's probably an issue with home base, right? It's probably an issue with the spine. So basically he found that activation, deep muscles are problems. Spasms or increased tone around the deep muscles of a joint can compress the peripheral nerve root and produce something similar to a radiculopathy. So he found that it was also important to treat the spinal segments as well. These are the three models. I'm not going to get into these because we don't really have time. But the gun model is the radiculopathic model. The trigger point model was that by Travell and Simons. They used something called the energy crisis theory and the motor end plate hypothesis that had to do with the changes that occur within the musculature with the insertion of the needle. And the functional model is something that's out there now by Kineticor. It essentially is an eclectic model to dry needling where they're utilizing the trigger point model, they're looking at the radiculopathic model, and they're utilizing the CNS in movement. Pain is important, but movement to them is essential, right? That's what we do. We're experts in movement, right? So that's why we're utilizing the functional model, or why I utilize that. Patient populations, who do we use the dry needling with? Those with chronic musculoskeletal dysfunction, those with chronic pain, patients that have trigger points, restrictions in range of motion, CNS impairment. You can use this with patients that have CNS dysfunction. There's more and more literature coming out now with application to this in patients with multiple sclerosis, patients that have had a CVA and CP. Patients that have had a CVA, I'm not reversing the neurological injury that they have. That would be a miracle. I probably would walk on water after leaving the treatment, right? That's not what I'm doing. But those patients after that insult will accumulate dysfunction, and oftentimes may not have the ability to do their exercises at home. They're getting really bad rehab, and so they accumulate other tonal changes, dysfunction. Their limbs essentially become non-useful. The dry needling will help restore tone to that acute injury, right? It will help reset things. It's not that they dry needle and walk away. They're still going to need intervention after that, but that's why that's being applied to that particular population. And more studies being looked at and utilizing it in patients with fibromyalgia just because they have trigger points, right? Indications by diagnosis. So treating by diagnosis to me is not helpful. As a physical therapist, someone comes in with tendonitis, I don't give them ultrasound. That's not how we do things, right? Not how I do things. But these are things that, as a physician, if you're prescribing dry needling or you're interested in dry needling, these are the things that it probably would apply to. Most here are all associated with orthopedic problems other than phantom pain and chronic regional pain syndrome and the post-herpetic neuralgia that you may get with shingles. So those are all things that it can be utilized with. CDC guidelines for prescribing opioids in chronic pain. So the profession of physical therapy stands ready, right? CDC guidelines for prescribing chronic pain. So recently in 2016, these guidelines were released, and guess what? Physical therapy was in one of those guidelines as one of the recommendations that physicians can curb the use of opioids in their patients. Now, for me to stand here and tell you that physical therapy is a solution to opioid addiction is ridiculous. I would not do that. Physical therapy is a really important tool, and I think across service lines, whether you're an inpatient, whether you're in home physical therapy, whether you're in outpatient physical therapy, the best way that physical therapy can serve this cause and the physicians that are dealing with these patients is communication. That's the biggest way that we can essentially do this. Dry needling is a tool that we can utilize to help the medical community with some of these patients with chronic pain. They're still going to need multidisciplinary care. They're still going to need evaluation by a psychologist. They're going to have to deal with those struggles with addiction, but we are there to assist with this process. So again, all similarities begin and end with the tool. It is nothing more than dry needling and acupuncture. You know, I really think that all this headbutting that we're having between professions is a giant waste of time. You know, really what we're dealing with is we're using the same tool. That's it. And we'll show that, you know, there are recommendations out there that, you know, overlapping between medical professions is actually better to our patients because they can receive better care. So these are the dry needling practice rulings in 2002. Not looking good. All the gray, those are the states that don't have dry needling or have no decision. You'll see Pennsylvania and New Jersey is in there as well. In 2002, you had New Mexico, and you had New Hampshire, and you had Virginia and Maryland. Those were the states that were allowing dry needling. The red states, no way, not happening, right? So you can see the little frown and the thumbs up. Those are things that make me sad and happy, right? But that's where dry needling was at that state. When you get to 2009, wow, big change, right? So all the green states, again, have dry needling. Blue is also a yes, but the interesting thing about that, it is a yes, but it is also up to allied health professions' scope of practice to determine that whether or not they believe physical therapists have the ability to do so. I think that's really dangerous. It is not prudent to have another medical profession regulating. You know, for me to regulate what athletic trainers do or what physicians do is ridiculous. I went to school as a physical therapist. That's where my training is. I understand my profession, and I understand the training and everything that's involved with that. It's hard enough for us to regulate our own profession, let alone someone else's. So those are the blue states. The orange states, interestingly enough, are the states that have been told by their State Practice Act that if you feel that dry needling is safe and you have adequate training, have at it. That's dangerous, right? Green states, again, approved. You can see the difference here. Look at that, 2009 to 2015. Colorado was actually, after that state approved dry needling for physical therapists, that is when it was just like a watershed lesion where all these states started approving it and adding it into their practice. You can see New Jersey is in the green there. Pennsylvania is a definite no at that point. And New Jersey, the language was very ambiguous in our Practice Act, where the therapists were not precluded to doing dry needling. And that was actually because they tried to get it, the verbiage of dry needling put into our Practice Act, and they were denied. So they had to release an addendum saying they weren't, you know, it's not allowed, it's, you know, we're not endorsing it, but there's nothing wrong with it. 2017, Pennsylvania goes off the map, and what happened in New Jersey, right? No longer utilized in the state of New Jersey effective February 9th of 2017. No more new patients after July 1st. All cases have to be dismissed beginning September 1st in the state of New Jersey. So this is what was released in 2012 by continuing education providers, by the state board, 2 education providers, basically the New Jersey State Board of Physical Therapy Examiners. Statutes and regulations do not preclude the use of dry needling techniques or trigger point release by a physical therapist, provided the physical therapist is trained and competent in the technique. My question is, what does that mean? The Board of Physical Therapy Examiners does not consider dry needling the practice of acupuncture. This was the best way for our board to get this in play so physical therapists can utilize this intervention because they saw the value in it and knew and strongly feel that it is not the practice of acupuncture. But that was the best that they could do with the language. February 9, 2017, Director Lee, who's the Director of Consumer Affairs, requested an opinion to the New Jersey State Attorney General as to whether or not the Physical Therapy Licensing Act of 1983 authorizes physical therapists to engage in the practice of dry needling, right? Not good. This came like, a thief in the middle of the night. I woke up in the morning on February 10th and said, darn, this is not good for us. Not good for me, right? The letter ultimately said, accordingly, you are advised that under the current statute, physical therapists are not authorized to engage in dry needling or intramuscular stimulation. You mean to tell me I can't do that Monday morning? Yeah, that's what I mean. Can't do it. Not happening. So what I've circled in red here is really, really important. Okay, so scopes of practice overlap, says the Attorney General of the state of New Jersey. This is not me stating this because I want to perform dry needling. The Attorney General of the state of New Jersey said our courts have long recognized situations in which the scopes of practice of licensed healthcare professionals overlap, right? Primary licenses, physicians, dentists were able to perform or utilize needles as part of their care. Oftentimes they would be doing something called medical acupuncture, which is not, again, not dry needling, not the dry needling technique utilized by physical therapists or strategy, but shows that it's important for patient access, that patients have access to multiple aspects of care depending on the health provider that they're seeing. All right. In conclusion, dry needling is not within the scope of physical therapy practice. However, it was not based on the determination that the legislature only intended to recognize the use of needles being within the scope of practice of acupuncture. That's key for us as physical therapists because the Attorney General said himself that I did not tell you that dry needling was outside of your scope of practice because I believe that using needles is something that belongs to acupuncturists. Didn't say that. That is great for us, and it's great for our patients. So the activity itself, insertion of the needles in these points in the body, as with most medical procedures, has risks and contraindications which training is required. I am not dismissing that this is something that, hey, everybody just go pick up a needle. We're going to go and do this. It takes a lot of practice, a lot of education, a lot of your own research, just like any other aspect of your practice does. Knowing when not to use dry needling is a form of treatment is just as important as to know when it is appropriate, right? That's key with any intervention that we're providing. So does everyone get needled? No. Everyone does not get needled. One simply does not put needles anywhere, right? I'm not sticking needles in any part of the body that hurts. It's a very systematic approach, right? Is dry needling dangerous? There has been no disciplinary actions taken by the New Jersey State Board of PT Examiners related to physical therapists performing dry needling. Claims which suggest dry needling by a physical therapist are dangerous are without merit. CNA, most of us have liability insurance by HPSO, is a major provider of that. CNA, their underwriter, said in 2014 there were no trends relative to dry needling which would indicate that that presents a significant risk factor, nor do they expect an immediate rate or claim impact on dry needling. That's telling. They're the ones that are underwriting the insurance policies for physical therapists, and they're looking at it saying, I don't really see this going anywhere. Potential complications. What are the most common things that you're going to see greater than 10%? You're going to see pain with needle insertions. Sometimes you'll get pain with the initial needle insertion. Patients will develop muscle soreness. Some of the literature that's out there now is suggesting that it is the technique of needling that's used. You can piston the needle and move it back and forth. You can spin it. You can wind the needle. Those are showing to have different results and generate different complaints of soreness among our patients. Fatigue and bruising. That is not scary. Patients get bruising with manual therapy and soft tissue mobilization already. I don't want to bruise my patients, but it happens. Everybody's a little bit different, right? Uncommon things are aggravation of symptoms, complaints of feeling faint or dizzy, a stuck or a bent needle. Are you kidding me? A bent needle? Yes. No, I'm not kidding you. I've seen it. Generally, those patients that are very, very large, have significant amounts of muscle mass, particularly a bodybuilder, the contraction of the muscle. I have seen a needle bend. That is not something that you take lightly, and you abort mission when that happens. The needle comes out, right? Headaches, you can see as well. Very, very rare. Infections and pneumothorax. That is what scares everybody, the pneumothorax, right? Oh my gosh, don't put that near my chest wall. I don't want you to puncture my lung. That's incredibly rare, and not only that, there may be a genetic component to that as well. Those are clinical questions I'm going to be asking my patients before I'm doing needling. Have you ever had a pneumothorax? Do you have a family history of that? If there is, I'm just going to be prudent because I love my license and I love practicing physical therapy and helping patients. I'm not going to be putting a needle in that person, right? We'll talk about a study with that. Vasovagal responses, patients feeling faint or dizzy. Initially, when you're learning those needling procedures, patients are receiving this treatment lying down in a supine position, just in case they have any of those vasovagal responses or have issues with feeling like they need to faint. A forgotten needle, what are you doing? That shouldn't even occur. GI issues, neurological responses, emotional responses, anxiety, euphoria. I've seen that once in all of the times that I've either performed or witnessed a dry needling treatment. Patients basically lose it when they're dry needled. It triggers an emotional response, maybe a traumatic history in their lives. Those are all really good questions to ask before you're going to be performing dry needling on a particular patient. So you said pneumo what? Are you kidding me? Pneumothorax? No, I'm not. But in 1970, they identified acupuncture and dry needling as an additional cause of iatrogenic pneumothorax, spontaneous pneumos. Not a good situation. Thank God for the study in 2011 where McCutcheon found that while examining safety concerns with acupuncture and dry needling within the thoracic region, international practice prospective investigations looked all over the world and found the United Kingdom 0 out of 66,000 cases, both examining physicians and PTs, no cases of pneumothorax. In Japan, 65,000 cases, all PTs, no pneumothorax. Czechoslovakia, these were all acupuncture studies. They had one case out of 69,694 cases that was a hospital-based physician, right? In Germany, acupuncture medical professionals, they examined 1.3 million cases and only found one case of pneumothorax. So you can see that it's not something that this is, you're going to talk to your neighbor across the pond and say, boy, have you ever had a pneumo? Yeah, I had 3 last week. That doesn't happen, okay? Does not happen. Not to say that when you are needling the rib cage, if you look on, there's plenty of YouTube videos out there about dry needling. If you look at someone needling levator scap and upper trap, those are two very popular regions in which can produce a pneumothorax. Those are things where I should not go, geez, I hope I'm hitting the levator scap, because guess what? The chest wall and the lungs are underneath that. So there are techniques and procedures that you can take to be prudent and make sure that you're not going to touch that rib cage. Clean needle techniques. The techniques that we're using in the clinic are very safe, clean, right? You don't want, I think twice if I was a patient walking into a clinic and my therapist was wearing sandals, was eating his breakfast and said, hey, do you want to be needled, right? And there's Burger King wrappers on the table. Those kind of things would make me nervous. That's not what happens when you're dry needled by a physical therapist that knows what they're doing, or by a physician or a chiropractor, what have you. Sanitize and keep gloved hands prior to and during the treatment. The needles are always sterile. There's a clean treatment field that's free of clutter. There's sharp containers nearby to dispose of the needles, and you're going to be washing your hands between patients. That should be the way that you're practicing anyway, for the most part, when you're putting your hands on people, right? So, not a shocker there, hopefully. Problem with the research. Additional high-quality studies are needed. There's lots of systematic reviews out there that are slightly better than sham or no treatment. Ironically, a lot of the high-quality studies are showing sham no better, slightly better than sham or no treatment, but then the case studies are showing amazing results. Why do you think that is? Right? Case studies are what? Are they important to PT practice or medical practice? It's what your colleagues are doing for the most part, right? It's a piece of that hierarchy of evidence that we're going to be looking at. It is a very important piece to be looking at. However, it does not face the rigor of standardizing the testing protocol and all those other things. It's not an easy thing to study, but they're figuring out and it's getting better. The focus of research previously was on the trigger point. Now it's going to be, you're going to be seeing more and more studies coming out on the cause of neuromuscular dysfunction and its impact on movement. Pain is great. I fix pain, that's a win for my patients. If I help them move better, that's why they're coming to see me, right? So that's where the studies are looking at focusing now. The APTA in 2011, dry needling was included in the list of manual therapy techniques in the Guide to Physical Therapy Practice. Why is that a manual therapy technique? That's a modality, isn't it? Well, no, it requires skill to utilize the dry needling, and it is, I'm within the actual muscle belly, right? So it is highly skilled. Healthcare profession scope of practice. One activity does not define a profession, but it's the entire scope of activities within the practice that makes any particular profession unique. Simply because a skill or activity is within one professional skill set does not mean another profession cannot and should not include it in its own scope of practice. We're not looking as physical therapists to steal anybody's thunder, right? We're all about serving our patients. This is one more tool that we can use to get our patients back to their prior level of function. So recommendations for dry needling practice. Education, education, education. Anybody that loves their profession, which I know everybody in this room does, we're looking at things every day. We're learning every day. We're looking at studies. Some of us participate in research. Others of us are utilizing that and implementing it in the clinic. Acupuncture and dry needling are considered to be very safe among competent practitioners. Advanced techniques require advanced education. Dry needling may be implemented as part of the comprehensive approach to rehab. I really think when it comes down to PT and acupuncture, we're butting heads for the wrong reasons, right? I should not be fighting over whether or not I think the technique that I'm using is the same as what they're doing. Our problem within our profession is that the guidelines and the educational requirements are not clearly established with physical therapy. I promise you that is going to change. Does anybody know what happened on Friday? That's a PT in the room. How many PTs do we have? OTs. PTAs. OTAs. Physicians. Chiropractors. Everybody's looking around. Where are they? All right. Acupuncturists. No. Athletic trainers. Okay, great. All right. So Friday, our Practice Act was updated, right? 1983, a long time ago, right? So intramuscular techniques have been more clearly defined in the updated Practice Act, which basically wound care was within our scope of practice. Now it is very clearly stated in our Practice Act in terms of intramuscular techniques. This does not mean we can go and put needles in people yet. That is going to be a legislative battle that's coming down the pike, more than likely. Other things include changes to PTA supervision, all kinds of good stuff. Please look that up. You should know that. All right. State licensure laws and Practice Act. Communication. Advocacy with your state board. Become an APTA member. Go to chapter meetings. If you're not, does not matter what medical profession that you are in, you should belong to your professional association. As someone that dry needles, no longer dry needles, but if I'm doing dry needling and this is a struggle within my practice, and I don't care enough to spend the $500 to $1,000 to join my professional association for a group of individuals that work hard every day to fight for my ability to keep doing the things that I love to do every day, shame on me, right? That's really important. Our profession's worth fighting for, right? Cliche, but it's true, right? Those are my kids. That's important to me. This is Eliana and Rachel. So Eliana is 5 now. Rachel is 2. At every stage, at every parent's life, they have the child and they say, well, what kind of embarrassing outfits can we put our kids in? That they really, until they're 4 or 5, have no choice. She's waiting for a flood. We put her in a poo outfit that was way too small, but we decided we're going to stuff her in and take a picture anyway. And those are them a little bit older, a couple summers ago at my sister-in-law's wedding. Any questions? It's got to be a question. Sure.
So are you using just one needle at a time, or are you using multiple needles?
It depends.
Okay.
That's probably the best answer I could give you. So if I am utilizing, treating a peripheral musculoskeletal problem, say for example at the bicep, and I know it's a bicep issue because I've looked at myotomal screens and took into account their history and all those other things, I'm just going to needle the bicep. If I feel that there is central involvement or segmental involvement at the spine, I'm going to be treating cervical spine as well. There are things that you can utilize. You can use a point stimulator with your patients. If I know that 2 needles are a problem, 2 muscles, nearby muscles or synergists are a problem, I can treat both of them at the same time. I can also have a patient prone on the table, for example, if they are having lower back pain. I can place needles to the lamina of their lumbar spine, hook them up to essentially E-stim for the most part, and allow them to receive benefit for that. That's, in my opinion, way more effective than just putting a couple of electrodes on their back and hoping for the best, right? So I'm very specifically treating the muscle that's the problem, and it is because I have tested that out and I know what myotomal regions are involved based on my testing. So sometimes I will use 2 needles, but it's not like I'm putting 6 or 10 needles in someone's body. If that's happening, maybe when you have more advanced training, that may be something that you see. But generally, the way that I'm putting needles in a patient is very methodical. I may have 1 or 2 needles, at most when I'm treating those patients.
So if you have somebody with like fibromyalgia, like where are you starting at?
Generally
Come in
like
everywhere hurts.
Yeah, right. So, I'm in that case, that's a problem, right? And that says it hurts here. Well, okay, dink, right? I put a needle in. That's probably not what I should be doing. I'm going to be looking at movement overall and probably seeing what movement limitations they have and what's the most troubling for them in terms of their function, which can be outlined with the outcome measures that you're utilizing. That's going to probably tell me where I need to start.
Does it have any positive effect on spasticity?
Well, if you're looking at the operational definition of spasticity, where it is a CNS driven process, it's not going to reverse that initial insult of the neurological injury to the brain or the spinal cord with the dry needling, but it will change resting tone. So if a patient that have had a CVA or a stroke may have tonal changes to their gastroc, their soleus, their lower leg, their upper extremity that they've acquired because of disuse and lack of activity, lack of range of motion. Those are things that I can go in and treat and make a positive change with those patients and change those things that have occurred after the initial insult. Anything else? Yes?
Do these work as a series of treatments or
No, this is not like I've had interventions before where I had hip pain and I've got to go for 12 visits in order to learn whether or not I'm going to get any better. To me, that as a clinician and as a patient, it's a waste of time, right? Unless I know that the studies pan that out. But the patient may come in. Generally, this is not something that I'm going to need to do. Okay, well, what we're going to do? We're going to set you up for 20 visits of dry needling. After that, I think you're going to be better. That's disappointing to say that to a patient, and it would be disappointing to hear it. So more oftentimes, I will be dry needling a particular region of the body, a particular muscle, a particular spinal segment. That'll occur for 1 visit. Patients generally, they get off the table, they feel much better. Sometimes they have post-needling soreness, but within a couple of days, I see them again. If they say, wow, I'm 50% better, I'm probably going to do it again. That kind of makes sense. I think a lot of times as clinicians, we kind of throw the baby out with the bathwater. The patient says, oh, I'm better. And we say, oh, okay, that's good. And we move on to something else. We don't ever completely finish the intervention we're applying. We don't keep doing the same thing that's working. When the intervention I'm applying is no longer working, then I move on. Right? So that could be a visit. It could be probably 2 to 3 visits where I know whether or not that's beneficial. After that, after I've greatly reduced their pain, I'm working on movement. I'm restoring motion, getting them moving, because that's going to actually help improve blood flow to the tissues. Big picture with dry needling, it is setting the ground for tissue healing. That's the reason why we're using it. That's not something that the patient's going to come in, I'm going to do it for every visit. Setting the ground for tissue healing, I want to decrease their pain, I want to get them moving, and then it's off with exercise and function. Anything else? No? Thank you.
Before you guys leave, I do want to just clarify something. One of the most recent map that Dr. Owens mentioned showed that Pennsylvania went off of the map. It was no longer red, it was gray, and New Jersey went to red. He mentioned a lot of the struggles with New Jersey. One of the things in Pennsylvania, it is not necessarily against the Practice Act, but it is definitely not within it either. It is a middle ground, and I am currently fighting with the state to get this approved for Con Ed. They are arguing that it is not within the scope of practice, although that is not true based upon their own legal statement. So their legal counsel is currently working with me to alter that. It is approved for Con Ed credit in New Jersey, but I just wanted to let you guys know that, and I did send out an email about that yesterday. And then you wanted to state something?
Hi. If you guys don't know me, my name is Joe Patnella, and I'm also a victim of Brian Owens. When he took that class, part of their training is you have to do 200 trials or 200 sticks. So I happened to say that day that my hip hurt. And when somebody comes at me with sharp items, I run like hell. So Brian got me and said, well, where's your pain? And it was my gluteus. So he then proceeded to expose my butt in front of the whole clinic. Everybody came around at lunchtime, and he stuck a...
Your recollection is different from mine.
It was well, I wanted to say that no way it's going to hurt, You're not going to make me bleed. I'm not going to get a bruise. Don't touch me. Those are all the things I'm thinking in my mind. And then I'm thinking, okay, Joe, you just spent $3,000 of the hospital's money to send me to this class. You better shut up and take the treatment. So I lay down on the table. Everybody gathers around, and I'm ready to yell. Holy crap, this is going to hurt. So put the needle in, and I go, when are you going to put it in? It's already in 4 inches into my gluteus, and I didn't feel a thing. Then I wanted to say, where's the blood? No blood. Where's the pain? Relatively, it didn't hurt. He did hit the trigger point. I knew when it was. I knew when he hit my ilium, but it did not hurt. I would not say it's uncomfortable, and I'll tell you, it really worked. And when he finished, he said, you're going to be sore for a couple of days. You're going to feel this, but it's going to make you better in the end result. And it actually did. And then he said, well, now we got to treat your leg, and now we got to treat your anterior tib, and went down my leg over the next couple of days, so he got 2 or 3 more sticks out of me. And then I recommended to other folks who were appropriate for the condition, but it worked. And I wanted to be, I'm a physical therapist, and I said, why the hell do we put needles in anybody? There's no reason to do that. But this, God bless you, this does work. And Brian has an excellent technique, and he did also put the electric stim on the needle as well. So it's not a separate stim, it's a separate stim unit, but the stim goes through the needle that he put inside of it. 1 or 2 needles, and the most he ever did was 2 at one time. So, Brian, it was an excellent lecture. Thank you very much. For the acute care team, I'd like you to stay around after the meeting. We're going to meet for another half hour. Everybody else, thank you very much for coming.
Yes.
And Stephen, thank you for putting on this incredible lecture series.
If you notice with your quiz, you have to complete, that's 10 questions. That's Steve's fault, not mine. They're easy, though.
And thank you guys very much for the people who are presenting online or came online. Thank you.
Thanks.
Thank you very much.